Thank you very much for the introduction, and thank you to Dr. Fauzi for inviting me. It's a great honor to be here. It's my first time in Cairo, and I will give two lectures. The first one is about lung cancer screening, introducing lung cancer screening in national screening programs. So you all know that lung cancer is the leading cause of cancer death worldwide. These are some figures from Europe about the number of new cases, the number of deaths, and the lifetime risk. And the reason is because when lung cancer is diagnosed based on symptoms, 80% of lung cancers are at advanced stages, which are not eligible for curative treatment. And this is the role of screening to depict the disease at an early preclinical phase where it could be possible to perform a curative treatment. And if we consider the WHO criteria for screening, they are all fulfilled for lung cancer. It is a significant health problem. The population at risk is known. It is represented by current and former smokers. The screening test CT is sensitive and non-invasive, and when diagnosed, the disease is treatable. And a brief overview of lung cancer screening history. You all know that in the 70s, the Mayo Lung Project failed to demonstrate benefit from chest X-ray screening. And this is the reason why for 30 years nothing happened until in 1999, Claudia Enschke published this LCAP study demonstrating that in a participant at risk, low-dose CT is capable of diagnosing the disease at an early stage with 96% of operable stages. But the study was not randomized, and this is the reason why the NLST study was undertaken and finally published in 2011. And this study demonstrated a benefit of low-dose CT screening, but at the cost of a lot of false positives. Nevertheless, in 2013, lung cancer screening was undertaken in the US. 2017, lung cancer was the first cause of cancer death in both sexes, including also in women. And finally, between 2018 and 2019, we had the results of many European trials that were all positives, but also who adopted a different strategy, allowing to dramatically reduce the rate of false positive, only 2% in the Nelson trial. And this led us to conduct a mission of information at the European Parliament. This is me with my colleagues. And this was on November 2019, because we needed to raise awareness among our politicians about the benefit of lung cancer screening. And as of May 2022, the report of the group of chief scientific advisors recommended to extend screening to include lung cancer among the recommendation. And very recently, as of September the 20th, the European Council modified its recommendation that was previously from 2003 to now include lung cancer, considering the evidence for screening. But there are some challenges for implementation. The first one is the need to train radiologists to lung screening. And this is what we undertook with my colleagues from the European Society of Thoracic Imaging, because it is very important to ensure that lung cancer screening is practiced at a similar quality level to the trials that have proven its value. So with my colleagues, we defined this training program that was approved by the European Society of Radiology in January 2019. It is based on e-learnings webinars. I think that we had a good guess because it was just before the pandemic. But since it was based on online teaching, that could work. And we also conceive hands-on workshops on how to use CAD systems, and we have also recorded sessions on nodule cases, and the first certification exam took place this year in Oxford in June. So by going to the ST website, it's possible to apply for this certification program and to download some technical standards where we recommend performing very thin slices. We recommend the use of iterative reconstruction or deep learning reconstruction. And we have some dose recommendation. It is divided by a factor of 2 as compared to the Nelson trial. And according to the participants' weight, the volume CTDI should be 0.4, 0.8, or 1.6 milligray. And this is extremely low dose. So why hands-on workshops on CAD? The reason is that the management of screen-detected nodules in European trials is based on the use of volumetry software and volume doubling time measurement. And this allowed us to considerably reduce the false positive rate as compared to the US trial NLST. And the management is very simple. Large volume nodules, which are very rare, represent a positive screen result, meaning that we need a multidisciplinary team assessment on the management. Small volume nodules represent a negative screen, and for nodules that are indeterminate, that are intermediate in volume, we perform a shorter follow-up at 3 months, where volumetry software are capable of detecting early growth. This is not possible based on the diameter, sorry, but it's possible if we use volume. And the second reason is that most trials use double reading, but for implementation, it's going to be complex. So we believe that CAD could be used as a second reader to avoid detection error. And if we go back to this paper published in 2012, they demonstrated that the sensitivity of CAD is much higher than the sensitivity of double reading. And here there's a case where there's a nodule, which is not very easy to depict. I don't know if you see this nodule. And I did not detect the nodule, but the CAD detected the nodule. And we also have recorded sessions on nodule cases. And this is to share our 20-year experience in nodule for general radiologists that are not experts, to explain pitfalls like this pitfall, which is quite frequent. This is not a nodule, this is a linear atelectasis. Some false positives. This is not a cancer, this is an arteriovenous fistula. And we also explain the over-diagnosis risk, which is mainly represented by subsolid nodule. You have here 3-year follow-up, and you can see that this nodule has to be just followed up because the solid portion is minimal. Another challenge for implementation is the use. It's very important to use structure report templates. This minimizes the false positive, because we have strict criteria for positive screen, and it allows us to be homogeneous. And again, we can download some basic template from our website, and this is the structure, sorry, it's in French, but this is the structure report that we use in the Cascade study, where we the readers just have to click on the different situations, meaning that they don't have any effort to remember all different possibilities. And especially for indeterminate results, according to the different situations, they will have the date for the next short-term follow-up, which might be 1 month, 3 months, or 6 months. Another challenge is to combine lung cancer screening with aid for smoking cessation. It makes no sense to screen patients and not to help them for smoking cessation. And this is a very strong recommendation from the European Council that implementation studies should be coupled with planned and organized smoking cessation interventions. Another challenge, since we detect positive screen results, we need to have a fast management pathway, which has to be defined beforehand. And very important, it's important to have efficient invitation and re-invitation strategies. There was this experiment in a department for France which failed to have a good adherence for the second round of screening, which was only 35%, and this is not acceptable. What about the reading modalities? What is the role of AI? This is important to simplify the process. Most lung cancer screening were based on double reading. And what about the role of AI? Google engineers claimed that they were capable of diagnosing lung cancer more efficiently than human doctors, but there is no prospective validation. And secondly, their model was trained on NLST data, meaning CT scans that were performed 20 years ago, and this is outdated CT technology. So there is no proof that applied to our current extremely low-dose CT scans, this algorithm will have a good performance. So this leads me to my project, the Cascade study, where the main objective is to compare the performance of a single reader, a general radiologist, but who has been trained in lung cancer screening and who is using AI as a second reader, with a standard of reference, which is double reading by expert radiologists, and this in a campaign targeting only women, and I will explain why. We have a list of secondary objectives to evaluate the performance of AI as first or standalone reader. We will evaluate the screening adherence according to different strategies. We will evaluate the psychological consequences of screening, the influence of screening on smoking cessation. We will detect other comorbidities, COPD, coronary artery calcifications, and osteoporosis, and we will evaluate the costs induced by screening. And we had the support of this patient association, Lung Cancer Europe, and I sent this letter to our Ministry of Health to convince them that we needed to be funded, because this patient association estimated that the study was crucial. So why women? So first, I don't think, this is not because we think that we should not screen men, but there are some reasons. First, women were underrepresented in most lung cancer screening studies, and the last sentence of the Nelson paper was more research is required in women. Second, we have an extremely worrying situation in France regarding the epidemiology of lung cancer in women. We had recently, it was published in the Lancet Regional Health very recently, and this survey from our general hospitals reported that the proportion of women amongst lung cancer patients, that was only 16% in 2000, in 2020 it was nearly 35%, so it has doubled. And it's important to raise awareness among health professionals. Lung cancer is not a disease only affecting men, and also to raise awareness in women about the dangerosity of smoking, because for an equivalent tobacco exposure, the risk to develop lung cancer in women is nearly 2 times higher. Third reason, from an organizational point of view, we can combine breast cancer screening and lung cancer screening, because it's exactly the same thresholds. And this paper from Ugo Pastorino demonstrated that biennial screening, meaning screening every 2 years, like for breast cancer screening, is safe. And lastly, there's a very important benefit of screening in women in all studies. At 8 years in the Nelson trial, the risk reduction is 59%. It's really huge, but since there are very few women, the confidence interval is quite wide. And this again is to illustrate this worrying situation. You can see here the curve in France about the number of, I don't know how to, yes, with the arrow. Okay, so you see that it's really increasing. And also in Sweden, and I think it's the country where the incidence in women is higher than in Sweden. So for going back to this pilot study that I coordinate in France, the Cascade, we will be recruiting 2,400 women. Currently we have more than 500 in 4 different regions: Paris, Rennes in Brittany, Béthune in the northern part of France, and Grenoble in the French Alps, to have different profiles. Regarding the screening invitations, we had important media coverage to invite women to participate by calling our centralized team. There's a national phone number and an email. And during the first contact, our research technicians check the eligibility depending on the smoking history and making sure that the participants are asymptomatic. And they program an inclusion visit with a pulmonologist who explains the study, who evaluates the situation for other screenings. What was the date of your last mammography? There is no physical examination, but just questions. And then they evaluate the cigarette dependence scale, because in the waiting room, all participants feel this cigarette dependence scale, and it's very important that they do that alone, because it's the occasion to become aware of their addiction. And they, of course, suggest help for smoking cessation. We perform baseline CT, then at 1 year later, and then at 2 years. And we will be collecting all CT scans. We are collecting all CT scans centrally in a dedicated PACS. On-site reading is first performed without AI, then with the help of AI. The experts do not have access to AI. And my project is, when we will be having all the baseline CT, is to evaluate different AI solutions as first reader. What is the performance? Is it true what is claimed by the Google engineers that they do better than us? We will see. I hope it works. So why using AI? Because some nodules are obvious. This is the case in the first image. Others are more subtle. This one in this patient was only detected by an expert, but also by AI. And then very tiny nodules. This is a solution that I have at my hospital, in my department, to detect lung mets in oncologic patients. And I can assure you that all radiologists have a look at it before validating their report. Each time they open a case, they have the solution already available. They don't have to go to a workstation, and no, it's already available. And so some preliminary data, we had a strong adherence because there was an important media coverage. And within the first 3 weeks, more than 1,000 women reached the team. Initially, the rate of eligibility based on the smoking history was 51%, because at first we started with 25 year smoking history. But it was so disappointing to tell the participants, you are not eligible because you did not smoke enough, that I asked for an amendment to reduce to 20 year smoking history, which increases the eligibility rate to 57%. 472 inclusions that were already read by the 2 experts. We have a 2.7 cancer detection rate. This was not expected to be as high as it is. Just for you to know, in the Nelson, it's 0.9%. So meaning that women are really at risk. Centers outside Paris only opened recently, and this month, November, we will be starting the invitation through the same letters that are sent for breast cancer screening, thanks to a collaboration with the centers coordinating the breast cancer screening. And these are very a few examples. This is a negative screen reader for all readers, the on-site reader, the expert readers, and 2 AI solutions. This is a positive screen result, and that was confirmed after a percutaneous biopsy that it was a lung cancer. All readers, on-site, experts, and the different AI solutions were positive. This was a lung cancer that was not detected by one of the AI, but by the other one. And this is a false positive detection for all readers except the expert readers. So, because it was an arteriovenous fistula. So we need to adapt our teaching program to show this kind of pitfall. And we had a case of active tuberculosis in a woman that was totally asymptomatic, and I checked if the AI detected that there was something wrong, and it was the case. Just for you, it's really low dose. It's 0.4 volume CTDI. So the AI detected that there was a problem. And to conclude, if I want to summarize my talk, introducing lung cancer screening in national screening programs requires, first, training the radiologist. It is extremely important about the technical requirements, about the dose, about some pitfalls. Second, it's mandatory to use CAD AI software equipment to play the role of second reader and also to calculate the doubling time for indeterminate nodules. It's mandatory to use structured reports defining the criteria for positive screening. It's important to have quality assurance program with 2 things that need to be checked, the dose and the proportion of positive screens. A center that would have 20% or 10% positive, there's something wrong. And lastly, it's very important to have aid for smoking cessation, rapid management pathway, and efficient invitation and re-invitation strategies. Thank you very much for your attention.
Thank you, Professor Marie, for the first lecture. Now for the second lecture, titled Role of AI in Lung Imaging, Is It a True Addition